All right, so now we're going to begin our discussion of Chapter 3 in Essentials of Human Disease and Conditions. That we are going to be focusing on immunologic diseases and conditions today. So we're going to start with a quick overview. Functional components of the immune system. We have lymphoid tissue, which is primary and secondary divisions. Primary lymphoid tissue is where the lymphocytes actually develop. The thymus develops T cells, and the bone marrow develops B cells. Within those two systems, this is where the T and B cell develop what's called immunocompetence. It's where they learn to do their job properly, and cells that do not do their job and pass an antigen test before they're released are actually killed off. Our secondary lymph organs are things that either house large numbers of lymphocytes or are areas that secrete and create factors related to signaling of the lymphatic tissue. So here's a quick diagram overviewing the different areas of the immune system. Other things that are important to remember is that our skin can be considered an immune organ, as well as things like saliva in the mouth. Those are all barrier type function. As we talked about in our first lecture, the immune system can have different types of malfunctions. You can have hyperactive response or hypersensitivity response, like allergic reactions, immunodeficiency disorders, where the immune system, for one reason or another, is unable to react at an appropriate level. And then autoimmune disorders, where the body develops antibodies against itself, so it attacks itself. And then you can have attacks on beneficial foreign tissue. This would be transplant rejection. So transplant rejection primarily comes down to the fact that every person's cells have our own antigens, which are markers on the cell surface that indicate the tissue and cells belong to us. Every person's individual antigens are different. If these do not match up, the body will attack it. So if you're taking an organ such as a kidney from a donor and you're placing it inside of your body, that kidney will have different antigens. The important thing we would have to do then is actually shut down the immune system. So when people are given anti-rejection medicines, a big part of those medications' function is to suppress the immune system. And they suppress the immune system by a lot. Because realistically, any damage to the new organ is typically fatal, which is why you typically need a transplant in the first place, because you can't live without that organ. This is just a quick diagram highlighting the problems with transplant rejection. The main thing is you'll see an antigen from the donor organ. It ends up activating both B cells and T cells. The B cell antibodies will bind to the donor kidney, and the cytotoxic T cells will directly attack the kidney. That results in vascular injury, which, as you will learn about with the clotting cascade, that can cause blood clots. It can lead to DIC, which is diffuse whole body coagulation of blood, which is a deadly event. You get damage to the organ itself as well. So remember, this organ has been put in and it's supposed to function as a normal kidney. It's no longer doing that because it's been damaged. So the idea is that our immune system is activated when a foreign molecule enters the body. Our body's first response to that molecule is to produce antibodies, and those antibodies help coordinate the other types of immune cells to target them. Specifically, are T cytotoxic cells, macrophages, neutrophils, and NK or natural killer cells. In fact, natural killer cells, highly effective for the defense of viruses. Development of immunity really begins again when we talk about the myeloproliferative cells, well before they become lymphocytes. And believe it or not, our red blood cells and other types of blood cells, they all kind of stem from the same stem cell. They're these generic myeloproliferative cells. They start to develop, they go through different responses, and we kind of end up with two primary divisions, T cells and B cells. T cells that we're talking about here, the primary types that we're going to talk about are cytotoxic T cells and helper T cells, but we also have other forms called suppressor and memory T cells. Those have highly specific functions, and they're kind of like mediators, whereas helper T cells kind of point the cytotoxic T cells in the correct direction. And they also play a role with helping stimulate the production of more B cells. As you can see here, we get kind of a generic rundown of how a B and T cell are made. So with immunity, one of the primary things we want to talk about is cell-mediated immunity. There's generic. There's two types. There's our cell-mediated, which is derived by T cells, and we have antibody or humoral mediated immunity, which is our B lymphocytes, again related to antibodies. Immunoglobulins, coming from our B cells, we have 5 primary types. Each of them kind of has a different role. Like IgE is a big one as it's related to allergic reactions. IgG is incredibly important as it is one of the main immunoglobulins, and it's also important for a developing fetus, as it's the only immunoglobulin that can cross the placenta. We have IgM, which is kind of the first antibiotic that's made and produces a very generic response. And again, they all stimulate the immune system. They all have a slightly different shape, can bind different ways, etc. The primary way they function, though, is the antibody. You kind of think about an antigen as a lock, and the antibody as the key. Or sorry, other way around. The antibody as the lock, antigen as a key. These two things kind of float around until they fit together, right? And that stimulates what's called the complement system, which is a inflammatory response that has a couple different outcomes that either results in the creation of more inflammatory mediating cytokines, or the actual phagocytosis and destruction of the pathogen. We also have active and passive immunity. Our active immunity is when you get an exposure to a disease. And then we have passive immunity, where our body kind of has benefits against a pathogen just because of the way our body functions. So, quick rundown on the complement cascade. Again, you've get antibodies binding, and it ultimately leads to this membrane attack complex, where the membrane of the pathogen gets attacked, and water diffuses into a bacteria. Using this specific example, water diffuses into bacteria, and it actually ruptures the bacteria membrane. Acquired immunity, as we already talked about, you can be given natural or artificial means, and passive or active. So immunodeficiency diseases. We have increased susceptibility to bacterial infections resulting from B cell deficiency, and there's increased susceptibility to viral, fungal, and protozoas, typically from T cell deficiencies. Some conditions can be genetic or acquired. So, talking about HIV and AIDS. HIV and AIDS is primarily related to T cell deficiency. So Kaposi sarcoma and lymphoma are one of the most common, but we also see other opportunistic infections. In fact, all of the things you see on this list in a country like the United States are typically associated with immunodeficiency disorders. So Kaposi sarcoma is a malignancy of blood vessels, and you actually get blue and purple patches all over the body. We'll see a picture of it on the next slide. The pneumocystis carinii, or P. carinii, pneumonia, is a lung infection. It is typically life-threatening in a person with AIDS. Tuberculosis, as we know, is caused by Mycobacterium tuberculosis, highly infectious condition, not very common in developed countries, but it's relatively contagious. We have our herpes simplex and herpes zoster. That's your chickenpox, your shingles, things like that. Typically not a big deal, relatively common diseases, but they can be incredibly harmful in somebody that has immunodeficiency. Candida albicans, which is a fungal infection, typically associated with its thrush, right? Then we have toxoplasmosis, which is a protozoa parasite, and neurologic complications, typically related to excessive inflammation of the nerves, neuropathy. There's also an AIDS dementia, things like that. So you see here, this is Kaposi sarcoma. This is on the lateral heel. Perennial herpes, hairy leukoplakia of the tongue, another condition associated with AIDS. So remember, AIDS is the progressive impairment caused by the human immunodeficiency virus, HIV. Typically starts off with generic flu-like symptoms, and people can be healthy for years and have latent periods. Typically, though, you eventually develop conditions like encephalopathy, malignancy of your lymphoma or Kaposi's, dementia, death, etc. A lot of people with HIV also succumb to those opportunistic infections like those we described before. So there are two types of HIV. HIV primarily disrupts T lymphocytes, specifically the T helper cells. Without the T helper cells, we don't really get a effective coordination of our immune response. HIV also has a direct effect on the nervous system, and it's typically associated with direct contact with blood or semen and other bodily fluids. In practicality, sexual contact is the primary transmission. We're talking about diagnosing it. We look to the lab to do a test called a ELISA, which is an enzyme-linked immunoabsorbent assay. And then you would take that test and run some other tests like a Western blot, etc. There is no cure, but there are some important treatments that do exist. There is highly active antiretroviral therapy, or HART, which is a 3-drug combo that consists of 2 nucleoside reductase inhibitors, and then another form of inhibitor. Depending on the type of HART, it's either a non-nucleoside reductase inhibitor or a protease inhibitor. These things are all related to helping reduce the amount of the HIV's RNA, because HIV is a RNA-based virus. We have become much more successful at treating AIDS over the years, and every year the number of people dying from the condition is decreasing. Next, we have CVID, or common variable immunodeficiency. It's a B cell deficiency, which means we actually end up with decreased antibody production and functions. The most common initial symptoms are lymphadenopathy, splenomegaly, hepatomegaly. Remember, inflammation of these lymphoid type tissues basically means we have an excess amount of lymph tissue, or lymphocytes, sorry. Meaning if we have a B cell deficiency, our body's going to naturally want to make more B cells. So then we get the swelling of these organs because B cells hang out in these organs. People with these conditions have increased frequency of autoimmune diseases, chronic lung diseases, specifically granulomatous diseases like a sarcoidosis. If a person's a child or teenager, they typically get frequent infections. We don't really know the two causes, but we typically see the most common group being between 18 and 25 years old, and a small group that's between 1 and 5 years old. A lot of people that are treated with this, they get immunoglobulin replacement therapy, so like a intravenous immunoglobulin IVIG therapy. You get regular monitoring for infections. You have to be careful about antibiotic usage, hospitalizations, etc. Most of the people with this condition actually end up dying to chronic lung diseases or cancer. Next is selective immunoglobulin A deficiency. The most common way that this presents is recurrent otitis media, which is an ear infection of the middle ear, sinusitis, which is sinus infection, or pneumonia. Typically is asymptomatic for a majority of the time, though. What we're seeing here is failure of B cells to produce adequate levels of IgA, as the condition is aptly named. Treatment is geared towards infection management. Again, prophylactic antibiotics, which may not be great, but people like this don't have a high-functioning immune system to begin with. IVIG, especially with IgA, could be highly effective. Next is X-linked agammaglobulinemia. It's characterized by the absence of serum immunoglobulins and increased susceptibility of infections. The people tend to have absent tonsils and adenoids, which are basically bigger lymph nodes present in and around the lower part of our mandible. Enterovirus infection is very common with these people, and it only affects males because it is X-linked, as we discussed before. When you talk about X-linked diseases, it requires only one of the X chromosomes present on the from the mother or father to pass this along to a male child. Treatment, again, try to improve the immune defense. Infusions of globulins, IVIG, again, very, very great. Appropriate antibiotics. These people also tend to get a lot of the inactivated vaccines that are using either dead pathogens or they're using antigen-based vaccines where, not the whole pathogen is given, but a very specific part of the pathogen. Severe combined immunodeficiency, or SCID, group of disorders. Typically, you have a wide range of T cell and B cell dysfunction. And in fact, in the most severe cases, there's pretty much no immunity provided by T and B cells. You get severe recurrent infections of just about any type. Lymphoid tissue might actually not even exist in some of these people. They might not have lymph nodes. They might not have tonsils. It's a major problem. One of the big red flags for this is actually a pneumonia in the first week of life. There can be X-linked or autosomal recessive forms of this. They're both caused by genetic mutations. Currently, the only known way to cure this is a bone marrow transplant, but gene therapy is currently being looked at. Typically, unless successful treatment occurs, the child will die within 1 year of birth. Next, DeGeorge anomaly, congenital condition of immunodeficiency resulting from defective development of the pharyngeal pouch system. So when we're developing in utero, our body kind of develops out in these patterns. And one of the most primitive forms that we can classify these down to are these pharyngeal pouches. The pharyngeal pouches can be roughly associated with different anatomic areas and functions. But typically with this specific person, you get heart abnormalities, issues of thymus development, and all of the abnormalities mentioned on the screen. Interestingly enough, they also tend to have parathyroid glands non or underdeveloped, which leads to issues with calcium regulation in the body. So this is what somebody with thymic hypoplasia would look like as an infant. Notice the low set ears, and some of the other descriptors present on the previous slide. What you get here is the third and fourth pharyngeal pouch, again, not developing properly. Those things are associated, again, with your heart development, your aorta, parathyroid, and other important structures. So treatment, they typically want to do a thymus transplant and bone marrow transplantation. A complete anomaly, though, one where you pretty much have all of the issues, it's pretty much always fatal within the first year of life due to failure of the cardiovascular system or infection. Next, we have chronic mucocutaneous candidiasis. So candidiasis refers to infections related to candidal infections. These are fungal infections, essentially. In really severe forms of this, you actually get fungal infections in the respiratory tract, which is not normal, very dangerous. That's what candidiasis looks like. This is, I believe, in the throat. There's multiple different types of syndromes, and they primarily affect mucosa, but it can also affect the skin, and you can see effects of on the adrenals, the thyroid gland, parathyroid gland, and ovarian failure. This is another form where you can get it affecting like the feet, the skin. The people here have a T cell deficit specific to candida, meaning the body never produced a T cell lineage that would react to candida. That means there are no cytotoxic T cells that attack candida in the body. That's not very good because our other immune cells like neutrophils and macrophages, while they will, quote unquote, fight candida, they're very slow and inefficient at that. Typically associated with a gene mutation of the STAT1 gene. And the primary way to treat it is systemic antifungals. Next, we have Wiskott-Aldrich syndrome. So this is an interesting condition. Another one that's related to both B and T cell deficiency, or I should say inadequate function. But they can also be in low numbers. We see a lot of bleeding issues with this one. So you can end up with thrombocytopenia, severe internal bleeding, and increased susceptibility to infections, particularly bacterial and viral, because anytime there's bleeding means that some sort of barrier in the body has been broken, which means a pathogen like bacteria or virus can get into the body. In these people, you typically see a smaller than normal thymus gland. Even though our thymus gland is largest at birth, and it does decrease in atrophy throughout life in a normal person, these people already have a small thymus gland when they're born. They also tend to have issues with platelet synthesis, so that's why you see the bleeding issues. Treatment is bone marrow transplant. That's about the only thing you could do. And splenectomy. They use this because, as you recall from A&P, the spleen is kind of the recycling center for our blood cells of just about every type. They go to the spleen, they get recycled. Well, if you want to increase your number of platelets, you take out someone's spleen, which it kind of seems counterintuitive, but for a person with this type of condition, it's very important to stop those bleeding complications. Typically, people with this condition, they have a median survival rate of only 25 years, but those that don't receive bone marrow transplants or splenectomies, they tend to die within 5, which is very bad. We also see IVIG and prophylactic antibiotics. All right, so next we're going to go on to autoimmune diseases. These are where the body's antibodies target our own features of our own body, right? The body inappropriately attacks itself because it does not identify it as self. There's lots of different things that are related to this, and sometimes it just happens as you get older. Sometimes it's environment. Sometimes it's genetic. We also see some associations with viral infections, certain drugs, etc. All can increase your risk of autoimmune disorders. First one we're going to talk about is autoimmune hemolytic anemia. So hemolytic anemia is essentially where the body destroys its own red blood cells. When we're talking about the conditions here, though, fatigue, weakness, chills, fever, itching, in this specific context, this is almost a emergency situation. There are 2 different subtypes, but we don't have to dive into that very in depth. The most common test for this is called a Coombs test, which looks for autoantibodies on red blood cell surfaces. And basically what they do is that test tries to bind those antibodies while it's on the red blood cells, which causes the red blood cells to kind of coagulate together, and that can be measured. Sometimes there are underlying diseases or drug use that can cause it, like corticosteroids for the warm body type. And then there's cold body type. People actually can develop it from just being in the cold weather. Very dangerous for people that live in northern altitudes that have this condition. And it's surprisingly one of those conditions that you can treat pretty effectively by moving to a more temperate climate. Pernicious anemia is the impaired vitamin B12 absorption, which causes a B12 deficiency. And what you get ultimately as the true underlying cause is chronic atrophic gastritis. So you get atrophy of the stomach, specific aspect of the stomach related to hydrochloric acid, and a shortage of something called intrinsic factor. Intrinsic factor is incredibly important for digestion related to vitamin B12. Essentially, what you're getting is antibodies specifically produced against parietal cells of the stomach. Parietal cells produce both the hydrochloric acid and the intrinsic factor. So pernicious anemia realistically looks like just about any other type of anemia. You're going to essentially check for it by doing laboratory testing for B12 levels on top of a complete blood count where you look at your factors like your red blood cells, your hemoglobins, your mean corpuscular hemoglobin, and mean corpuscular hemoglobin volume. All of those things come into play. Now, what sets B12 apart from other types of anemia is that it commonly affects the peripheral nervous system. It's related to demyelination of the peripheral nervous system. So the person can get muscle atrophy, they can get tingling in the hands and feet, they can get tinnitus, which is ringing in the ear. All of these things are related to B12 deficiency. And again, these nervous system symptoms typically only happen in somebody who has a chronic form of this condition and more severe forms of the condition. The best way to treat it is injections, intramuscular injections specifically. Since the body cannot digest B12 dietarily, you cannot take a B12 supplement orally for this. This has to be done with an intramuscular injection. In some cases, they do suggest doing a blood transfusion. Next, idiopathic thrombocytopenic purpura. We'll see a picture of this on another page. But this is a acquired disorder related to deficiency of platelets. So the person starts to kind of have pinpoint bleeding or petechia. It is idiopathic, meaning we don't actually really know the underlying cause. And one of the most common things you'll see, as you see on this page, is kind of these pinpoint hemorrhages under the skin. And again, there's nothing that's going to cause these widespread hemorrhages. This isn't like a normal bruise or anything like that. Treatment is typically related to corticosteroids to increase capillary strength. They do use IVIG and vitamin K administration. Vitamin K is specifically K2, incredibly important in clotting. The primary way we get vitamin K is actually from the bacteria in our gut. It actually produces it and as a waste product, and our body actually absorbs it. Again, another fascinating interaction between bacteria and our own bodies as we actually need it. Next, immune neutropenia. Basically, we just have a reduced number of neutrophils. Remember, this is the one of the first responder white blood cells. We also will see anti-neutrophil antibodies created. You get a lot of recurrent infections in people with this condition. Goodpasture syndrome is a autoimmune kidney disease characterized by the presence of antibodies against the glomerular basement membrane. You get acute renal failure, blood in the urine, systemic complaints related to decreased kidney function. It's a very life-threatening condition and essentially can cause glomerulonephritis and pulmonary hemorrhaging. Typically self-limited, but if somebody has Goodpasture syndrome, they need a pulmonologist, they need a nephrologist, and it's very important to have treatment effectively. Next, connective tissue diseases. This is a family of conditions where the immune system attacks collagen and other types of connective tissue. It's believed that genetics have a big role in these, but we're finding that actually the environment might be very important too. First one we're going to talk about is SLE, systemic lupus erythematosus. It's a chronic inflammatory autoimmune disease that is characterized by unusual autoantibodies in the blood. You typically see various types and subtypes of what's called anti-nuclear antibodies. In fact, that's the most generic diagnostic test for this. One of the more common diagnostic things that you will see is the butterfly malar rash on the face, which we'll see a picture of on our next slide. But you can also get rashes that are photoreactive on other parts of the body. And that's another potentially key feature for this condition, is that the rashes get worse when exposed to sunlight. We don't know what specifically causes SLE, but it's thought to be an autoimmune disease. One of the more interesting things about SLE, people tend to have joint pain with this condition, and that's related to something called an immune complex. Immune complexes are basically antibodies that bind to antigens that are bound to other antibodies bound to antigens. And with SLE, you actually see these immune complexes getting deposited inside of the joint. Okay, so you're not getting damage to the joint itself, but you're getting inflammation within the joint, and that inflammation can cause pain responses. In the most severe cases, you actually get something rather interesting with the hands. Like a lot of these rheumatological conditions, you'll look to the hands because we have small joints there, so the effects and damage are more readily seen. But again, there's no damage in SLE. Well, you can have something called a reversible subluxation of your metacarpal phalangeal joint, which is kind of your knuckle, right? Like if you were to punch a punching bag, you're putting a lot of stress on your metacarpal phalangeal joint. You get a reversible subluxation to where if the person's hand is just sitting on the table, at first look, that joint will actually look subluxed or partially dislocated. If you apply pressure then to the hand, that reverses. It's a rather interesting thing that can happen with these people. So here's a diagnostic criteria here. There's lots of things to it. But a big thing we have to be careful for with SLE is damage to the kidney, which is why they're always doing blood and urine tests, especially looking for protein urea. That is a negative prognosis for somebody with SLE. The more effect it has on the kidney, the worse off they're going to be. And in fact, lupus-related kidney disease is essentially the main reason why somebody with lupus actually dies. We can also get a type of leukocyte called an LE cell. That's kind of a laboratory-based thing, though, where they do something to white blood cells to cause them to change. But a big thing we're looking at here is your CBC, because you want to look at your leukocyte levels, your platelet counts, but then you're also going to do a arthritis panel where you look at stuff like your erythrocyte sedimentation rate and your C-reactive protein, which those two things are generic markers of inflammation. They don't indicate anything specifically, but we also want to look at our ANA test, our anti-nuclear antibodies, as well as for the ANA, the pattern of the ANA. There's different patterns, more in depth than we need to go, but the different patterns can also be related to SLE or other related connective tissue diseases like scleroderma that we'll see in a few minutes. Another thing you want to look for, though, to help differentiate it from other conditions is anti-DNA antibodies, anti-Smith and anti-chromatin antibodies. You're also going to want to look at anti-CCP and other your rheumatoid factor, which is, even though it's named rheumatoid factor, it's not necessarily associated with just rheumatoid arthritis, but there's a lot more to it. Diagnostically, SLE can look incredibly similar to a condition called Sjogren's syndrome. The only real difference between them is some of the specific values that would be abnormal. So you could have a anti-Smith antibody at a certain level that's abnormal in lupus, but your anti-Smith antibody could be abnormal, but at a different level in Sjogren's. This is one of the reasons why rheumatology is such a highly specific field. And you'll also look at complement levels and all kinds of other important immune markers to help differentiate SLE from other conditions. And even, it gets even more complex if somebody has SLE plus other conditions, like you might see in something commonly called mixed connective tissue disease or undifferentiated connective tissue disease. The treatment of SLE, anti-inflammation drugs. Some people start off with NSAIDs, typically high-dose NSAIDs, so it's not going to be like your ibuprofen you can get over the counter, but it might be something like Bloxcam. You need a prescription for. Interestingly enough, though, they do use anti-malarial drugs to help control the skin symptoms and the arthritis condition, the arthritis-related symptoms that I talked about earlier. This would be the drug hydroxychloroquine. Now, in people that don't respond to those NSAIDs or hydroxychloroquine, they will also use other immunosuppressive medications. These would be things like corticosteroids, which are very dangerous to take over the long term. They cause all kinds of things. And also drugs like methotrexate. So scleroderma, another connective tissue disease, is a chronic progressive disease characterized by sclerosis, which is just hardening of the skin, scarring of organs, etc. It's relatively systematic. You also get shrinking of the skin, and it actually, in those people, you look at their fingers and the skin over their fingers is very taut. You'll see an example of that on the next slide. You're going to have like a rough, leathery type skin, but again, autoimmune disease. There is a form of scleroderma called Crest syndrome. So what you're seeing on the screen here is the taut skin over the fingers. Crest syndrome is actually an acronym. So you get calcinosis, so calcium buildup under the skin. You get Raynaud's phenomenon, so the body does not respond appropriately to changes in temperature, specifically cold, and it can actually be incredibly dangerous and result in the loss of like a finger or toes or even a whole foot or hand. E is esophageal varices and esophageal hardening. So the esophagus, it gets tough to eat, to drink. S is sclerodactyly, which again, you're seeing a picture of that right now on the screen with the taut skin over the fingernails. And then T is telangiectasia, which is like kind of like spider veins, right? Very superficial in the skin. People with full-on Crest syndrome have a much worse prognosis than someone with just generic scleroderma. So treatment, again, wide-ranging condition, lots of different ways to treat it because of the different symptoms, etc. But typically you're going to order drugs based on the part of the body affected. This is another thing that rheumatology absolutely needs to treat, and patient education is huge here, especially when you're thinking about Raynaud's phenomenon and the esophagus symptoms. Both of those can be very dangerous, right? With Raynaud's, like I said, you can lose your finger, you can lose toes. With esophageal reflux, if it's too bad and too common, you can get actually essentially a hole burned in your esophagus from your stomach acid. You could also end up developing a just like somebody with gastroesophageal reflux disease or GERD can develop a condition called Barrett's esophagus, which is a metaplasia, meaning the type of cell in the esophagus mutates. It's a precancerous condition, right? And then eventually people with it have a much higher rate of developing esophageal cancer. That rate's still low, all things considered, but you've started down the route of essentially, giving your body the tools it needs to develop that cancer. Same thing happens with people with scleroderma. Sjogren's syndrome, as I mentioned earlier, incredibly similar to SLE, except the main difference starts to come when we look at the symptoms. It is common, though, it is possible for people to have SLE, Sjogren's, scleroderma all at the same time. Again, you can have something called mixed connective tissue disease, but and even rheumatoid arthritis fits into that. Sjogren's syndrome primarily affects glands, though, especially the moisture secreting glands, salivary glands. You can have dry eyes. In fact, you do a test called the Schirmer test for that, where they put a special dye in your eye and they look to see how the dye distributes. People often have difficulties with talking, chewing, swallowing, because again, you're not producing enough saliva. So as you'll see here, this is what somebody with a increased salivary gland could look like. And here is a picture of somebody doing a Schirmer tear test. Treatment is relieving symptoms, right? One of the most common issues with it is decreased tear production, right? One thing that they do with that is you use special eye drops, right? You ensure you're drinking enough water. They can block tear ducts with a implant to help maintain eye moisture. There's all kinds of things, but generally the treatment for this is very similar to SLE, very similar to Sjogren's. You're not just you're going to address symptoms, but you're also going to address the immune overreaction by using things like NSAIDs, corticosteroids, etc. Next, rheumatoid arthritis. Now, unlike the previous conditions that we've just mentioned that can cause joint pain, rheumatoid arthritis actually directly damages the joint. What you're seeing in RA is the immune system attacking the synovial membrane of the joint. This can also lead to synovial damage outside of the joint. There are certain tendons in the body that actually have synovial membrane, particularly around the hand, with your hand, wrist, and foot and ankle. There are several joints or several muscles and their tendons that are continuous with the joint and therefore continuous with the synovial membrane, and those can be damaged by this as well. In fact, with your extensor carpi ulnaris in your wrist, you can actually see erosion of the ulna. So you remember your pinky side bone of the forearm, your ulna can be eroded because of that inflammatory reaction. And in fact, what you see, it has a special name. It's called pannus formation. So that inflammation results in the creation of that pannus, and you get these symptoms. Now, again, RA is also has systemic effects in the body. You can get lung symptoms, bibasilar fibrosis of the lungs, and it also affects like the cervical spine. It can damage the integrity of the cervical spine. You can get some degradation of the longus coli tendons, which can lead to degradation of your atlantoaxial articulation, which then leads to the ability of the dens of your second cervical vertebrae to actually kind of be able to freely move, as your axis, your C1 vertebrae, is not sitting correctly on top of that anymore, and that can actually predispose people to upper cervical instability and therefore upper cervical spine injuries, which are typically fatal at that high of a level. So what you see here, the stereotypical joint affected is that metacarpal phalangeal joint. Right here, they get nice, they get swollen. But eventually, as you can see in our diagram here, the pannus forms, and in the most severe cases, the body actually forms new bone, and you have what's called ankylosis. So the joint no longer exists, it's now ankylosed. Our exact cause is unknown, but again, autoimmune disorder. People with RA typically are thought a lot of times to have SLE, Sjogren's, scleroderma, or even other conditions we haven't quite talked about yet, like polymyositis or dermatopolymyositis. Those are conditions kind of like if you take the idea of SLE, but apply it to muscle, right? So you get widespread muscle pain. With dermatomyositis, same idea as polymyositis, except for you're adding now in skin symptoms. But RA is one of the 4 inflammatory arthropathies. The other 3 are psoriatic arthritis, which is associated with a condition called psoriasis. About 15% of people with psoriasis end up with psoriatic arthritis. Psoriasis is the condition that involves the rough, scaly type plaques that develop on the skin, particularly on extensor surfaces. So you'll see it a lot on people on the elbow, the olecranon side of the elbow, the extensor surface. You get it on the backs of your hands, tops of your feet, things like that. But these conditions can occur with RA. RA can be on its own. The other two inflammatory arthropathies, we have another one called ankylosing spondylitis and enteropathic arthritis. Those two things kind of go together. Diagnostically, very similar, except for while ankylosing spondylitis is purely producing, like the lung fibrosis, the spinal ankylosis, things like that. The enteropathic form includes an inflammatory digestive disease like ulcerative colitis or Crohn's. And then we have something called reactive arthritis, which was formerly known as Reiter's syndrome. The primary thing that we think about with that is the saying, can't see, can't pee, can't dance with me, because the people with that condition, they normally have painful urination, they get conjunctivitis, and they have what's sometimes called lover's heel pain, which is pain in their heel related to the arthropathy. It's typically related to STDs like chlamydia and gonorrhea. But with all of these inflammatory arthropathies, including rheumatoid arthritis, their conditions are the treatment's very similar. Anti-inflammatory response, NSAIDs, corticosteroids. Except with RA, you might see people leaning more towards a little bit more extreme medications earlier on, things like methotrexate that are major inhibitors of the body's ability to cellularly divide, almost like not quite a cancer medication, but same kind of idea. So rheumatologists, again, highly specialized people, highly specialized form of internal medicine. I found that a lot of rheumatologists are incredibly intelligent people. The major unfortunate thing about rheumatology is that a lot of rheumatological conditions, they persist throughout the person's life. And unless they're incredibly severe, they don't necessarily cause death of the person. So patients are lifelong patients, which is why a lot of rheumatologists have wait lists of 6 to 12 months long. Incredibly unfortunate. So next we have juvenile rheumatoid arthritis, or JRA. This is going to affect children under the age of 16. Most commonly, though, the onset's between ages of 2 and 5. And it's polyarticular and systemic. Come with fevers, you get rashes, and we don't know what happens, but we do know that there are pathological joint changes. So you can see here, this is a young child's knee. This is not normal. It can be incredibly painful. But you treat the child in a way that's very similar to rheumatoid arthritis, but you're modifying the medications based on the child's body size, essentially. They do talk about a balanced diet and higher levels of protein and physical therapy. Incredibly important for these kids. And it's also important to ensure they remain engaged in school. So they might need special accommodations for school. Next, ankylosing spondylitis. We mentioned it earlier, but this is another systemic progressive inflammatory disease. But unlike RA starting in the hand, and ankylosing spondylitis tends to start in the spine, typically in fact the low back. The stereotypical patient for ankylosing spondylitis is your mid-20s, early 30s male patient who has significant morning stiffness that lasts longer than 30 minutes to an hour, right? It's not abnormal to wake up in the morning, have a bit of a stiff back, but once you get up, you get moving, it gets better, right? For these people, that stiffness doesn't go away, or it takes an excessive amount of time to go away. Eventually, as you will see here, though, in this man who has ankylosis of the spine, which again, aptly named condition, you have fusion of the spine. The primary way that this is diagnosed is a little bit of clinical testing, where you're looking for something like a modified Schilbert's test, where the person has actually lost range of motion because of the fusion. You can also check chest expansion when somebody's going from like a full inhale to a full exhale, looking to see how much the ribs move, because ankylosing spondylitis, your ribs are attached to your spine. So they are also affected. You get less rib motion. One major and rather interesting thing, though, is the antigen HLA-B27. That's human leukocyte antigen B27. HLA-B27 is one of the big diagnostic tests for AS. Now, big thing to think about here is, just like I mentioned rheumatoid factor earlier. Rheumatoid factor, very important for rheumatoid arthritis, but it's also important how much rheumatoid factor there is and what the clinical symptoms are. And in fact, I believe the numbers are about 70% of people with ankylosing spondylitis are positive for rheumatoid factor. I think it's 90% of people with ankylosing spondylitis have positive HLA-B27, but only I think it's 10% of people with HLA-B27 positivity have ankylosing spondylitis, right? So just because you test positive on some of these things, or a patient tests positive on some of these tests, does not mean that they're necessarily developing these conditions. It just means they have a higher risk factor, most likely. And when you're talking about things like your anti-nuclear antibody, your rheumatoid factor, your HLA-B27, it's also important to consider the level that it's present, right? The titer. If you have a low level of these things, you're unlikely to have a specific disease. And in fact, you can be, I think it's up to 15% of people are just naturally HLA-B27 positive. I think it's up to a quarter of people are naturally rheumatoid factor positive. Some of these tests are not very specific on their own, and that's why clinical examination is so important. With AS, though, they don't do surgical treatment for it, because essentially what's going to happen is it's still going to ankylose, right? You're just going to cause somebody pain if you fracture the ankylosis. And in fact, that's not a good thing. A fractured ankylosed segment is considered unstable. It's not good. It's associated with severe spinal cord injuries. But it is a long-term condition. People go through periods of activity, remission, exacerbation, etc. Next is polymyositis. This is inflammation of the muscle fibers. Typically starts with muscles next to the trunk and torso. Gradual muscle loss of strength. History and physical exam, though, are major for this. You need to rule out other muscular conditions like muscular dystrophies, which there's dozens of. You have to think about drug toxicity. A big thing with that is statin medications, which are used for cholesterol, and we'll talk about that in a later lecture. But statins have a very common side effect of muscle pain, thyroid disorders, and then other conditions like sarcoidosis and infectious diseases all cause problems here. But these people, they have weakness, they have pain to light touch, and it can be relatively widespread. Just like all these other conditions, though, immunosuppressive agents. Exercise therapy is also incredibly important for these people. Next is multiple sclerosis. This is an inflammatory disease thought to be autoimmune in nature of the central nervous system. It's a demyelinating disease. So remember, myelin wraps around the neuron axon, and it helps speed up nerve transmission. So typically people with MS have, they start off initially with weird sporadic type symptoms. They're not always there. They don't necessarily add up to anything, but eventually you get limb weakness, loss of vision, something called diplopia. You get unsteady gait, vertigo, facial pain, dysphagia, which is trouble hearing, hearing loss, or dysphagia is trouble speaking, swallowing, etc., hearing loss, impotence, and fatigue. As you'll see here, what this is showing, we have our sensory and motor tracts being highlighted here. Both of those become damaged and result in the symptoms. You get lesions in your central nervous system that are viewable on MRI, but typically one of the more interesting things that we find is one of the initial symptoms is actually observed in the eye. You can typically there's a certain pattern that you could look at in the eye to have an idea if somebody is likely to have MS or not. There's multiple different types of MS, but not something that we need to dive too far into here. Treatments of MS, typically corticosteroids. You need to use immunosuppressive agents. With MS, it's highly variable. People can die within a few months. Others can live 30 years with it. It's highly variable. Myasthenia gravis. So this is a progressive neuromuscular disease that's actually caused by autoantibodies to the acetylcholine receptors of the nerve synapse. So remember, when a nerve signal is sent, you have the synapse. Draw this real quick. You have our axon from nerve 1. We have our synaptic bulb, and then we have the synaptic cleft here, and we have the dendrite of nerve 2. Let's just, it doesn't look very good, does it? So we have our dendrite of nerve 2. All right, and we get acetylcholine released from the synaptic bulb of nerve 1 via a vesicle, and then it binds to the ACH receptors on the dendrite of axon 2. What happens is we have autoantibodies that destroy the acetylcholine receptors here. So what does that cause? And again, this is actually typically a condition associated with females. Not super young, but 20s, 30s. You start to see drooping of the eyelids, diplopia, difficulty with talking, chewing, and swallowing. Those are the big first signs. A big thing, though, is that people typically do develop weakness, but that varies a lot. These symptoms can develop suddenly, and it might concern people that they're having a stroke, especially when you think about the drooping eyelids, the double vision, the diplopia, and the trouble speaking. Those are all major signs of a stroke, but this actually isn't a stroke, and it's a somewhat treatable condition. You treat it with acetylcholine esterase agonist drug. It's called oh gosh, can't remember it off the top of my head, but you use that drug, and the idea is that it inhibits acetylcholine esterase, which is the enzyme that breaks down acetylcholine. So we're no longer breaking down acetylcholine. That means the acetylcholine can sit around in our synaptic cleft for a longer period of time. Therefore, there's higher likelihood that it's going to bind and the transmission is going to still be sent. All right. You diagnose myasthenia gravis with something called Tinsolon test. So you basically are giving the patient a substance that would improve nerve conduction for somebody with MG. The drug to treat it, now that I remember, the brand name is Mestinon. It's pyridostigmine. It's a acetylcholine esterase agonist. Next is vasculitis. There's a whole family of different types of vasculitis conditions, but they're all summarized by inflammation of the wall of blood vessels. There can be necrosing or small vessel, which is the two primary dividers. Small vessels typically result in petechia or purpura, as we saw earlier with idiopathic thrombocytopenic purpura. But you can also get slightly larger issues like ulcerations, edema. A lot of times people have pain or burning sensations. There are some specific lab tests to rule out vasculitis, but they are typically associated with other immune dysfunction. The other type is our small necrotizing vasculitis. These primarily affect our medium and large arteries, unlike the other aptly named small vessel. Depending on the exact area of the body that's affected, it's going to have a wide range of different symptoms. The big thing, though, is comprehensive blood studies. You need a CBC. You need your erythrocyte sedimentation rate. You need your other arthritis type panel factors. But then there's also vasculitis specific measures related to like subtypes of the anti-nuclear antibody testing, etc. But this is another condition that's actually can be treated by rheumatologists. You might also see other types of specialists treating this as well. All right, so if you guys ever have any questions, that's going to be it for this. Just make sure to ask.